Hi, my name is Jun Li. I'm an interventional cardiologist, endovascular specialist based out of University Hospital's Harrington Heart and Vascular Institute in Cleveland, Ohio. I'm one of the national co-PIs of the AVENTUS Thrombectomy trial. This was a trial specifically looking at the AVENTUS Thrombectomy system, which is an integrated catheter that allows us to aspirate thrombus. It's a large bore catheter that allows us to aspirate thrombus and retrieve the thrombus along with blood with an inline filter, hence minimizing the amount of blood loss and expediting the procedural time. In our current practice, in the current realm of pulmonary embolism thrombectomy, there's a lot of back and forth along with our systems when we move our catheters, for example, from one side of the lung to the other side, or if we have to do catheter exchanges, we have to remove multiple wires and dilators, etc., hence increasing the time of the procedure. So this system is specifically designed with a beveled tip such that we can actually traverse through the cardiac pathway as well as to one side of the lung to other side of the lung without requiring the back and forth of a dilator. So it's a very unique design in the catheter itself. In addition, the inline flow system, the filtration system, allows us to essentially separate the clot from the blood, allowing us essentially to return the blood directly into the patient without having to remove the blood from the catheter and then filtering it separately. So the two of those specific designs on the catheter helps enhance our efficiency of our procedures for this very sick cohort of patients. The AVENTUS thrombectomy system was studied in a way that we enrolled patients who are essentially intermediate risk pulmonary embolism patients. So these are the patients presenting with acute PE. The majority of them, 99% of them, actually had bilateral pulmonary embolism. And they all had a right ventricular heart strain, so meaning that the right ventricular to left ventricular ratio was elevated. In addition, 87% of the patients that were included in the clinical trial had elevated biomarkers, either in the form of troponin elevation or BNP elevation, suggesting, again, there is significant right ventricular strain. We specifically targeted the intermediate risk patients so that we enrolled an adequately sick cohort of patients. We wanted to understand how this device would perform essentially in a real world setting. The outcomes of the study, the primary outcome was looking at right ventricular to left ventricular ratio reduction at 48 hours post using a CT scan. So compared to baseline CT scan, the RV to LV ratio at 48 hours post procedure. The RV to LV ratio was a core lab adjudicated finding, meaning that a separate independent core laboratory analyzed the outcomes of our trial. The safety outcome was looking at major adverse events related to the device at 48 hours. In addition, our secondary outcomes also looked at the efficacy of clot reduction. So looking at the refined modified Miller score reduction, again, core lab adjudicated at 48 hours post-procedure. Lastly, uniquely in this IDE trial, we also looked at the quality of life improvement through a questionnaire, as well as a 6-minute walk distance, also at 30 days, looking at improvement throughout the short-term follow-up in our patients. The primary outcome, which was the right ventricular to left ventricular reduction, was significantly improved. We actually were able to reduce the RV to LV ratio by 0.47. So the baseline was 1.57. Our mean outcome was 1.1, essentially accounting for a 27% reduction in the RV to LV ratio. In addition, we had 0 device-related major adverse events at 48 hours, meeting our safety outcomes as well. The Miller score, the refined modified Miller score reduced by 8.7 points from baseline, accounting for a 35.9% reduction in this Miller score. In fact, this is one of the highest calculated Miller score reduction in all of the clinical trials looking at pulmonary embolism devices. The 30-day quality of life improvement and functional status improvement was also significant. We had a significant improvement in the pulmonary embolism quality of life questionnaire comparing from baseline, so before the procedure, to 30 days post-procedure. In addition, the 6-minute walk distance improved from 48 hours post-procedure, which was 245 meters, with an improvement to 365 meters at 30 days post-procedure. This pivotal trial really showed that the AVENTUS thrombectomy system is very efficient in thrombus removal. Aside from our primary outcomes and secondary outcomes, as I've highlighted, the other things to note of importance is that there was only one pass through the heart using this thrombectomy system in 60.8% of the procedures. So meaning that in over 60% of the patients that received this procedure, we only had to traverse through the heart with this catheter one time. We did not have to do multiple catheter exchanges, etc. The procedural time was also quite favorable. So we call it a catheter dwell time, in that the catheter is within the patient for the thrombectomy and blood return for only a total of 39.5 minutes, which is tremendous. In addition, 99% of the patients did have their blood returned to them with an overall estimated blood loss of only 49 milliliters. None of our patients required any blood transfusions within 48 hours after the procedure. After the AVENTUS IDE pivotal trial results, the next step for the AVENTUS catheter itself is actually to seek out FDA approval. Once that is approved, then it will be available for wider use. It's important to recognize that this is only the first step towards improving the efficiency of the procedure. There will be other iterations of this specific device to try to improve on the efficiency of the procedure so that we can treat these very sick patients in a timely fashion. Overall, from a pulmonary embolism perspective, the trials that are ongoing to look at thrombectomy versus catheter-directed thrombolysis versus medical therapy alone remain very critical in our realm in treatment of pulmonary embolism patients, such that we understand in the future as we go forward, really fine-tuning which patients are the correct patients for medical therapy, which patients are the correct patients for thrombectomy, and which patients are correct patients for catheter-directed thrombolysis. So much more to be done within the field itself in terms of research so that we exactly understand which patient needs what therapy.